And it is now my great pleasure to introduce Vina, who's a key member and on the sort of leadership team within the Pain Center, to kick us off. Thank you, Vina.
Hi, everybody. Welcome to our event today. It's so wonderful to see you all here. I've been saying this a lot recently, but with everything happening in the world right now, it's more important than ever to show up and do the work related to equity, diversity, and inclusion. So all of you here are doing the work, and I really appreciate that. And even online, thank you so much for joining us. So I'm thrilled to have the honor of presenting four esteemed panelists and some fun facts about them. I'll introduce each of them briefly before we dive in. But before we begin, I think it's more, again, important to recognize that we are settlers here on Indigenous lands. So I have a brief call to action I'd like to bring to everyone. The first is that the Dish with One Spoon Wampum Belt Treaty speaks about this area of the world, and specifically the Takaranto or Toronto area, which means where there are trees standing in the water. And I think from that photo, you can really see that Toronto was a meeting place and still is a meeting place for Indigenous peoples all over Turtle Island today. The other thing that I would encourage you to do is recognize that a land acknowledgement is really only a starting point. We really have to support the ongoing work of decolonizing our practices and indigenizing them. And this means thinking about white supremacy, colonial systems, and we redistribute resources, building relationships rooted in reciprocity, respect, and justice through centering Indigenous knowledge, voices, and leadership. The way you can do this is by donating to Indigenous-led organizations that are advancing sovereignty and healing, support Indigenous-owned businesses and artists, challenge institutions like the ones we're at to decolonize and prioritize Indigenization, and uplift calls for justice from residential school survivors and the missing and murdered Indigenous women, girls, and Two-Spirit peoples across Turtle Island. So this is me. So in terms of who I am in this conversation, I'm a person with lived experience of pediatric chronic pain. I was actually previously a sick kids patient, and now I'm doing my PhD with Dr. Jen Stinson and Dr. Chitra Lalloo in the iOUCH pain lab at Sick Kids. And it's been a really long journey getting here. I'm very passionate about justice, equity, decolonization, and indigenization, because this is where we have to go as a community to ensure we are hearing the voices of people with lived experience. We can't talk about equity, diversity, inclusion, and accessibility without thinking about the folks that we're not including disabled, diverse, low-income youth in these conversations. I have the pleasure of introducing Dr. Samantha Louis-Poon, who is a she, they pronouns, and she's a registered nurse, assistant professor, and community advocate. Their philosophy is rooted in building meaningful human and community connections through stories, art-based methods, and thinking and imagining differently to improve the health, well-being, and rights of future generations. Specifically, Sam is passionate about storying the untold narratives of the Asian diasporas across healthcare and social systems. Her clinical nursing background is in pediatric oncology and hematology and pediatric medicine. Their program of research, RAW, Reimagining Asian Wellbeing, is dedicated at advocating for the rights and well-being of Asian children and youth at the combination of research and community engagement. Sam is passionate about storing the intergenerational experiences of anti-Asian racism and knowledge systems used to support Asian youth well-being. Dr. Anna Hood is a lecturer and assistant professor in psychology in the Division of Psychology and Mental Health and the policy director at the Manchester Centre for Health Psychology at the University of Manchester. Dr. Hood's research examines the biopsychosocial challenges faced by pediatric patients living with pain, with a particular focus on children and young adults living with sickle cell. She has published extensively and collaborates on projects to understand pain from structural perspectives, develop mechanisms to create restoration and create pathways for justice to eliminate pain inequities. She was awarded the International Association for the Study of Pain, or IAS, Ulf Lindblom Young Investigator Prize for Clinical Science for her work with youth living with sickle cell in 2024. Lanri Tunjay Ajay. Lanri is a global patient advocate committed to addressing disparities in care and the hereditary blood disorder for hereditary blood disorders while strengthening equity, diversity, and inclusion in global healthcare systems. To support these efforts, Lanri was instrumental in the establishment of Sickle Cell Awareness Group of Ontario, the Ontario Hemoglobinopathy Patient Association, and the Sickle Cell Disease Association of Canada. She was also the past chair of the Network of Red Blood Disorders Organization, NRBDO, and a board member of the Black Health Alliance. Her effort to build bridges across organizations dedicated to sickle cell disease and other inherited blood disorders are increasingly worldwide in scope, most notably through her capacity as co-founder of the Global Action Network for Sickle Cell Inherited Blood Disorders. She has co-authored numerous publications and recognition of her continuing advocacy and leadership on behalf of individuals living with sickle cell disease and their family. So Lanri is amazing, and she also received several medals, including the Senate Canada 150 Award, and she was on the list of 100 Accomplished Black Canadians, or ABC, Women in Canada. David Manley. David has an honors Bachelor of Science degree in biology and a master's in journalism. He has been a science writer, presenter, editor, and educator for 15 years. David has worked at SickKids since 2014 as the research program coordinator of Kids Science, a science outreach and communication programs for patients at SickKids and elementary and secondary students across the GTA. This program runs events, including workshops, demonstrations, lab and inpatient visits, collaborations with the PACT and Child Life teams, and internship and mentorship programs during the summer. Kids Science is focused on programming towards youth from historically marginalized communities and neighborhoods, as well as providing a paid internship known as the Student Advancement in Research Program for research for Indigenous and Filipino students. So some fun facts. So David's fun fact is that he is a twin, but what I like most about this fact is his parents don't know which twin was born first. Yeah.
So to clarify, they say they know, but they haven't told us because they thought that the one who was born older would have a superiority complex over the younger one and sort of lord it over to him. So that's why.
As an older sibling, I approve this message. So Sam's special fact or fun fact is that they enjoy forest bathing, which involves going into nature and completely immersing yourself in that environment, which I think is so cool. And Anna has a hidden talent. I would not challenge her in a game of cards because she was a PA on a cruise ship. And I don't know if this is fun, but she was kidnapped on that. She's fine now. She's here with us. We're all good. But, we all come with way more lived experiences than we know. And for Lanri, my favorite fact about her is earlier this year, we had the opportunity to attend a Sickle Cell Awareness Group of Ontario, a celebration event for African History Month and Emancipation. And Lanri had the best jerk chicken there. So that's my fact about Lanri. So again, without further ado, I'm going to start the panel, and Liz is going to just switch the screen so we can see Lanri virtually with us. So my first question for Sam is, what are some strategies when engaging communities who may have medical mistrust?
Well, thank you for having me. It's a really big honor to be here, and thank you to the other panelists as well. And thank you for the question. So I think this is a really important question, and I think it's easy for for us to sit here and say, we can build trust, we can build connections, and that will lead to, better interactions. But ultimately, I think in healthcare, within the medical system, within research environments, we haven't been doing very well with this. People who have experiencing medical mistrust. So what I think in terms of this question is, first start by understanding standpoint. And what I mean by standpoint is understanding the different knowledge or knowing is being come from. And so by understanding where different standpoints are being understood by that are external to our own, that gives us a better understanding and awareness of why medical mistrust actually occurs. Right. And so when we have this understanding and we walk into care with this knowing and with this understanding, we can understand that medical mistrust comes from a place. We can understand that the healthcare system, that research institutes, and the whole system of this institution is actually still a tool of genocide, of colonization, of white supremacy. And these processes ultimately steal knowledges, steal cultures, steal health of people. And that takes away the well-being of groups of and communities of people, not just in the moment of time, but across generations. And that leads to future generations as well. And in that process, that takes away people's agency. So for me, from the standpoint of a nurse, I can understand when I walk into care that that's very valid that people experience medical mistrust. And so when I come from this understanding, we can then turn to prevention. We can turn to culture is prevention, right? When we're in the healthcare system, when we're thinking of cultural safety and cultural humility, these are important dynamics within the healthcare system and when we're healthcare providers and researchers. But we have to come from an understanding that nothing is owed to us in an interaction within the healthcare system. From a patient perspective or from people who are minoritized and as people who are offering care, even when we're offering culturally safe care, nothing is ever owed to us, but we can use culture as prevention in these interactions. And at the same time, when we are in an interaction that people do gift us with their closeness or vulnerability within a healthcare interaction, that is a gift, and we should honor that gift. And we can honor that gift through an action, a tangible action that we can actually do as individuals in the healthcare system, whether we're a healthcare provider, whether we're a researcher, to actually make changes to the larger system. Am I over time? I'm like, I'm just
Go for
talking. And those actions should be sustained, right? And so consistency is another thing. Consistency within the healthcare systems, these actions should be sustained, should be honest, and should be consistent as healthcare providers. It shouldn't change from time to time. It shouldn't change in different spaces and different environments. We should walk with intention and be able to walk into all the rooms, and those intentions should be able to ultimately stay the same. And that can then lead to the shifting of the trust over time. This is not going to happen today or tomorrow, but across generations, across time. And so that's what I would say in terms of working with people who have experienced medical mistrust, that it's valid, that we shouldn't try to change people in those interactions, but we can work with culture as a prevention in doing so. So that's my thoughts around that.
Wow, Sam, I feel almost speechless with everything you just said. It's quite validating as someone who's been through the healthcare system as a kid, been invalidated that kind of way. Now, as a graduate student, witnessing this continuing. And as you said, it's about slow change over time, repairing relationships, and remembering that, it wasn't too long ago when people saw a logo like Sick Kids, it was interpreted as harmful. And because they did harm. It's valid. And I really appreciate that perspective. And Landry, what are some strategies that you've done to communicate with the communities who may have medical mistrust?
Thank you so much. And I totally agree with the last speaker on her points on dealing with medical mistrust. But I also want to add that, medical mistrust comes from, different factors, including past experiences, lack of communication, misinformation, cultural differences, and societal norms. And in the area of sickle cell disease, which is where I am, and inherited blood disorders, these factors pose barrier to patient accessing viable care and treatment options. So I just want to bring us back to a study that was done on racial and ethnic differences in physician mistrust in the US. Katrina and her team noted that Black patients tend to be more distrustful of doctors than whites. And the reason is now far-fetched, right? The biases and systemic racism experienced by people who identify as Black, including those who have sickle cell disease in the medical system, coupled with research ills experience, such as in the Tuskegee study, has definitely led to medical mistrust, right? And I believe that the strategies that can be used, which we are also using, and which we're encouraging doctors, clinicians, researchers to also use to engage with communities who may have medical mistrust would be number one. You have to work with the community with absolute transparency, right? This is the way to build trust, right? They have to trust because there's a lot of mistrust due to personal experience, past experiences that have been built up. So you have to, first of all, look at ways to build trust. To build trust, you have to be absolutely transparent about everything. They should be at the table, right? Medical team should be open to answering questions. We know many times that, doctors are very busy when they see patients, and sometimes they're thinking, I'm going to give you 15 minutes. But sometimes the patient still has more questions. You got to spend the time with the patient, help to gain their trust. And when you're also talking about research, they need to see themselves in leadership when it comes to research. They need to see their peers, people who look like them at governance, decision-making tables. We always say the mantra to follow should be nothing about us without us. And just like the last speaker said, to see tangible changes is not going to happen overnight. It's a process. So trust building is a process. And it will not happen overnight, yes. But all involved must work towards achieving this, right? And it starts with those who are in leadership, either in research, in medical field, who are seeing patients, to start and engage them in a transparent and trusting way in order to start to reduce the mistrust and increase the trust. Thank you.
Wow, what powerful words, Landry. And it makes me feel so good that you are you are in the community leading change. And I think even at Sick Kids, we've seen the impact that organizations such as yours can make when we are trying to engage these families and patients in their care and in research. So that actually follows perfectly into my next question, which is for David. What strategies have you used to do this work meaningfully and thoughtfully?
Well, first off, thank you everyone for coming. Thank you for inviting me. My job is very different than everyone else is. I'm not a doctor, I'm not a researcher, I'm not a nurse. What I do is community outreach and engagement. So what I do is I find that different strategies are what is the best approach, because I deal with the current patient population in the main hospital as well as also the potential patient population, because I go out in the community, I go to schools, and I do science talks and interactions and demonstrations and workshops with kids all across Toronto and the GTA. And the thing is, working with a child, in their room or in one of the classes at the hospital is not that different than working with a child in the classroom. You just have to find out what works. The interesting thing about my program is that everything that I do, all the demonstrations and talks that I do, can be expanded upon for older kids or simplified for younger kids. And I do that through interactive experiences, experiments. I ask questions, we play fun games, because the important thing is that at the end of the day, with what I do, that the kids end up taking something away. I've had many students, after going through some of my programming, that they say, oh, I never thought about becoming a scientist before, or I've always wanted to ask this question to a scientist. Now, I never tell the kids I'm a scientist, but I tell them I know a lot about science. And that's the best part of what I do, is answering questions, because that's what I find, that's the approach that I find that works the best, because everybody has questions. And when you come from different communities, different backgrounds, you may not have that person that you can ask that question to. You may not be able to go to your father, mother, aunt, uncle, and ask the question. Like, I was watching a commercial, and it was for Tide, and the kid asked the parent, "Do crabs have eyebrows?" And I turned to my brother and I said, "No, they don't." That's an easy question to answer. But that's what I find is the best way to approach these kind of things, is that make it engaging, have them ask questions, and then have those questions spawn more questions.
That's amazing, David. Sorry. Oh. I can talk loud. I'm good. Hopefully they can hear me online. But thank you so much for that, David. And I think it really ties together with what Sam and Landry both said earlier, which is sometimes it's just about listening and answering questions compassionately and making space, So I think that's so powerful in the work you do. And Anna, do you have any strategies that you've used to do this kind of work thoughtfully and meaningfully?
Yeah, good, this is working. Just like everyone else, thank you. Just want to thank everyone for coming, and thank you for inviting me to be on the panel. I feel like I'm going to be echoing what the other panel members have said, and really just like listening and talking to people. I know sometimes that's like, oh, wow. But yeah, it really just having a conversation with people sometimes as a human, you're a human, I'm a human. Let's just remember that sometimes, right? There is a wall that can sometimes be between us, and thinking that I'm a researcher or clinician and this is somebody different, rather than we're just two humans in a room. So for me, sometimes it's been, I'm going to be talking about it in terms of research meaningfully engaging. And so sort of at the baseline is making sure people are reimbursed in terms of being paid and being paid equitably for their time, right? And so I'm going to just have that as the baseline. I don't know if Sick Kids has guidance around that. Good. I'm seeing lots of nods. It does. So wonderful. So use that guidance to be able to make sure. Now, what I've also found, though, and many of you might have found as well, is that there's other things that are meaningful for people who want to participate in that research, right? They generally have, the condition that you're interested in, and they want to expand the research that is being done about their particular condition and want to be involved for that reason. And so that is meaningful for them. But I think asking people at the beginning or having advisory groups and talking to them about what is meaningful. I work, just as many of you do, with children and young people. So many of them want it to be a line on their resume or CV because that's meaningful for them. So they ask, and how would I do that? How can I put that on the CV? So maybe if you have guidance, even at the beginning, show them, have a template, be like, this is something you can put in your CV. Tell them at the very beginning. I've written letters for university, that they've been involved in projects and their involvement in those particular projects. So that's meaningful for individuals as well. I think outside our academic institutions and papers, people have really find it meaningful to be involved in videos or animations, if lending their voices to those things. So I think you can think sort of outside the box and creatively, but I would suggest, as I started with, listening, talking to people, seeing what is meaningful for this particular group. And how that might be, because sometimes some groups it's challenging to reimburse them monetarily, right, depending on their status. So how can you supplement if you can't give them the full payments to be able to do that meaningfully? And I'll share one of I think it's my dissertation study. So a little while back, but I was lucky enough to be at a large children's hospital just like this, right? And so I assume you guys have an area where families come, and then I would have the caregivers and siblings would come, and just providing snacks and making sure it was a nice area so that families felt comfortable bringing their siblings. But then so many people were bringing their siblings. I was like, oh, maybe I should just test the siblings as well, as a control group. And then I said to the family, the parents were like, oh, I'm bringing them anyway. And I was like, well, yeah, we could pay you for the sibling as well. So it actually became part of my study because I'd made such a welcoming space. Families felt comfortable bringing multiple people to the center that it just added to the research as well. And I got a really sizable control group that I was able to compare against, which particularly with sickle cell, which is really useful to have, a sibling group rather than, some sort of external group that doesn't represent them well. So I would say try thinking about the box, but also making sure that that thinking is aligned with the communities that you're talking to.
That's a great point. Speaks to the ethics of actually engaging these communities in research, because not only are patients and families, dealing with school, dealing with family, dealing with cultural obligations, but also dealing with managing a medical condition. It's a lot. And it tells us that our expertise is valid when you compensate. It means that just like you, we have a seat at this table. And even better, if we can co-lead and co-create, that moves the work so much further. And as someone who has really benefited from somebody writing me a reference letter when I couldn't find any other sort of volunteer experience because I was managing my health condition, it went a long way in terms of my future. And I honestly wouldn't be here today sitting in front of you without those compassionate people. So now moving to Sam, we're talking about these ethics. So how do we move beyond tokenism to ensure meaningful and sustained patient engagement with equity-seeking groups, particularly in chronic pain research and care?
That's a jam-packed question. Yeah. So I would say first is that to understand that one person can't represent a whole group, right? That we have to have a diversity of perspectives, even when we're including minoritized populations, that yes, this is a perspective, but we have to move away from just having one person as a representation of an entire group of people. Another component of this when we're talking about tokenization is this idea that the component of the identity part. And so I do a lot of work around representation and identity, and how can we kind of look at the boundaries of that. And so what I've really come to realize is that it's more so about understanding the lived and living experiences of people and how that actually contributes to a more fuller, comprehensive, broader perspective of a topic connected to someone's identity which is linked to larger systems of oppression and how that person then has to navigate those systems. So it's, yes, it's about identity, but it's also linked to their lived and living experiences and how they navigate the system. And so when we link those components together, we're not just talking about solely the person's identity. And that oftentimes leads to tokenization of just someone's identity or just someone by just looking at them, right? And or just a component of them. So I like to lean into the component of the lived and living experiences and the moving through systems of oppression. To move these components, I guess, a little bit further. So I do a lot of, community-based research, and a component of this question was, how do we engage in this process without tokenizing? So I would say, I pull this a lot from my own lived experiences and my own positionality as, a queer person, as a racialized person, as a person with my own lived experiences in pain who does pain research as well. And so even in, I would say, community-led research, community-based research, because of the structures that are in place, sometimes this can lead to components that break up between models of us versus them. What I mean by that is we have groups of people that are in different spaces that conduct research, and then they include, based on good intentions, populations that have lived experiences, and they, co-create research or knowledge based on that. But what that often leads to is this topic of tokenization, whether it's based on good intentions or, moving in partnership. Sometimes this also is an othering topic, even based in community-based research. And so the question that I pose back is, how do we then have queer, racialized, disabled people with acute and chronic pain experiences actually be the ones to rise up and be the leaders who are taking on projects, who are leading projects, who are the ones who become researchers, whether it's in, institutions or academia, then they could be the ones to lead and partner with other people. It's a shifting of how we perceive and frame the structures that we currently exist within. It's thinking of these topics in a different framing while still working with what we, the resources that we currently have. And this ultimately comes down to different components like access into different systems. I wouldn't be here talking today if I wasn't given access into the academic system, right? So that begs the question of how do we get access into these systems for people with lived experiences? Another component is funding. How do we move away and actually decolonize funding? How do people with, with past or present privileges, actually don't colonize the funding? So it's not hoarding of the funding, it's not domination of the funding. Rather, it's people with lived experiences rising up to actually share their perspectives through funding. So it's a shifting of different components. And ultimately, it's coming at these topics with a different perspective, moving away from an individualist perspective and moving into more of a community care framework. So that's what I would have to say in terms of these components. And I know.
That's great, Sam. Thank you so much for sharing that, and also sharing your own lived experience. Like, as somebody who is trying to make my way in a research world with my lived experience to actually enrich the research I'm doing, it feels really great to see that being represented. And as you said, as what's been said, that representation matters. To believe that that can be you one day and shift that power, it's incredible. is incredible as someone with lived experience. So thank you for sharing all of that. David, so what are some creative initiatives you've done to support certain patient populations? So with thinking about marginalization and equity seeking communities.
Right. So, as alluded to in my little biography, I run a summer program called STAR, which is Student Advancement Research, and it is specifically targeted towards demographics that are typically underrepresented in biomedical research. So those who self-identify as Black, Indigenous, and Filipino. And we do everything that we can to try to eliminate barriers, which was mentioned previously, to make these students want to come here. The whole goal is to give them a taste of research. It's very quick. It's a very quick program, 6 weeks in a research lab, working on a sort of individualized project. And then at the end, they present. And what we do is we pay above minimum wage, we reimburse for transit, so that the students want to come here. So we eliminate as many barriers as we can so that they will want to come here, as opposed to, working at the McDonald's down the street. Because we want the students to be interested in science. We want these students to want to participate in science. Now, for patients, recently I've started working with the palliative care team, which I was a little nervous about, I'm not going to lie, because these are patients that, as you may be aware, could be approaching the end of care. And these are patients that there is no real end in sight for their treatment. So they usually ask these patients, what are they interested in? And that's where I come in. Basically, the best way to think of my job is that I'm a science clown for patients. So I go in, I make slime with them. I flew paper airplanes with a palliative care patient for 45 minutes who knew more about planes than I did, which was super impressive. Because, as we've mentioned before, experiential learning is what people remember the best. Learning about something in school, learning about how flight works is very different than being able to experience it. And even if, this patient will never ride in a plane or something like that, being able to give them something to remember, something to think about when they are so passionate about science. And so that's why I think I was asked to participate in this panel, because my job is so different. I get to interact with the community, I get to interact with patients, I get to interact with some of the fine researchers here at SickKids and put it all together and get kids these experiences. And I think that is something that can really, really help change a child's perspective. Maybe they'll have the inspiration to pursue science as a career, or maybe not. Not everybody does, but that's okay. But everybody should have an interest and a passion for science. And I think that's something that more people can do to foster in both inpatient and outpatient populations.
I love thinking of that, like the connection between everything in the work you do and building those bridges, because I know they don't exist as a patient who went through the system myself. And I think there's so much power in your experience and what you're doing with these children and youth and patients, as seeing them as full people, like a plain expert, which is a whole different lens than what they've ever been looked at by people in the system, who oftentimes are just looked at based on their race, based on their weight, based on whether or not they're using a mobility device or assistive devices. So, that is very powerful, like that experience in of itself. I know for myself, I wouldn't have gotten started in science unless, Jen's here, but, she showed me a robot that they were working on. I was like, wait, you can build robots? Like what? Wait, we can make apps? Like what? So, it changed the trajectory of my life, because I was going to write the next Twilight. So, and now I'm here. I'm doing my PhD. I'm writing a thesis instead. So now moving on to Lanry. So these are what's really special about a lot of these questions that actually all been submitted by you in this room. So one of those questions is, how do we initiate partnership with an organization from an African country like Mali, which is where this individual who submitted this question is from? Lanry?
Thank you. Thank you so much for the question. I wanted to say that the way we do things are different from the way that things are done in Africa. And even when we talk about Africa, the different countries also operate differently. This is to say that there are cultural differences in the way organizations function in different countries, and we must learn these differences before moving forward to work in a foreign, either you are working with a foreign company, a foreign organization. You must learn how things are done in that space. In my own work as the CEO for Global Action Network for Sickle Cell and other inherited blood disorders, I lead over 80 patient organizations across 35 countries. And that allowed me to work with many countries and many organizations in Africa. My opinion is if you want to initiate a partnership and a lasting partnership, it's very important, number one, to first understand the goals and the needs of that organization that you are hoping to align with. That will also help you to see if there is an alignment or not, and to also be able to identify areas of collaboration. In many countries that are considered low and medium income countries, such as Mali, we know there are limited resources for many things that they do. And I know this firsthand because one of my member organizations is in Mali. And so to build a partnership that would last, you also have to look at how are you going to support them? What are their needs? What are their goals? And how do you contribute for them to achieve those goals and to overcome those needs? So in essence, it has to be a win-win partnership. They cannot see you as you're coming to take advantage of them. As such, I would recommend that in developing a proposal, when you're hoping to start partnership with them, you first of all have to outline what is the partnership goals, what are the activities that will be done by who is doing what, and what are the benefits to both organizations. There has to be absolute transparency and trust. And both partners, your organization and the African organization, you have to see each other as equal partners in the work that will be done, and they have to be included throughout your partnership processes and so on. So in other words, it's not a situation of we're up there and you're down there, but you have to be humble. You have to come to their level and work with them, that they can feel that you are a partner with them in advancing whatever cause that they are very passionate about. And I always say, where resources allow, it's also very important when you're trying to build partnership with an organization to visit them in order to learn more about their work. They see you in person, you sit down, and that honestly will help to advance, trust and, and also respect. And they need to also know that their voice matter, and that will help you achieve to build a lasting relationship or partnership with the Malian organization or any other, a country that you're trying to work with. Thank you.
Thank you, Lanry. And that's such a great perspective. I love hearing about all the work, amazing work you're doing across the globe. And again, we're so lucky to learn from you and learn how you are initiating these partnerships. Anna, from your perspective, how would you initiate partnerships like this?
Just thank you, Landry. I think many of the points that said, I echo. So I can speak about some projects that we are still trying to develop because grant funding is hard through to Ghana. So that develops through a relationship, really. So one of the people I work with very closely, a co-PI, is Ghanaian. She lives and works in the UK as a researcher. And wanted to do research in Ghana. And so she had many connections, obviously, in Ghana. She's also a nurse. And so really, I joined the project. But actually, I may be equal, but I consider myself less. I'm bringing, expertise, but Brenda and Andrews and Mary, my Ghanaian colleagues, are the ones who can discuss and talk about the Ghanaian context in a way that children and young people in Ghana will understand. And I feel like I'm always learning. One thing I learned in this project was that in Ghana, a transition, which I'm particularly interested, begins at 14, right? So lots of the things I think about developmentally and the way I've worked in the US and the UK, I've got to think about that differently now, right? We've got 14-year-olds in adult wards, and we've got to think about, I'm thinking about self-management and how do they manage work through their living with sickle cell. That's going to look very, very different, right? So I'm a learner in that, and I've got a lot of understanding, but I'm still coming in as a learner. And so we have a global health grant. I was telling Vina at lunch that things that have gone on in the US in terms of taking away global funding have also affected us in the UK in response to what happened in the US. So unfortunately, our grant is on an indefinite pause, but I will share that for the most part, the UK collaborators are coming in for capacity strengthening. We see that as our role. Also, the money, right? So the UK has, before it was indefinitely paused, but we had the money, so we can bring the money. But then the majority of the researchers, all of the research is being done in Ghana, and we're there to help capacity strength and for it to sustain longevity. And so that's the way I see these partnerships, in that we are coming in with special expertise, but that expertise in no way supersedes the local expertise, and we have to honor that and make sure that we're working with individuals. So I'm a co-I on that grant. I'm not the PI. Brenda and Andrews are the PIs, and I'm coming in with expertise, and then I also get to go to Ghana at some point. So that'll be good.
I hope you take me with you. But I think that's so powerful. And thinking about, in a Canadian context, truth and reconciliation and how we're going about doing that, a big part of that is leading with humility and recognizing that we don't know everything, and the scientific ways of knowing have only existed for like 200 years. And Indigenous people have been doing this since time immemorial. Like you can't even count it. So I think it speaks a lot to not only how we approach these relationships globally, but even right here on our land in Toronto. So now I'm going to open it up for some audience questions. You can feel free to raise your hand, and if you have any questions for our panelists. I think people are just stunned.
We have everything solved. We're done.
I think we solved all the world problems right here. But I actually maybe I'll direct this to Anna. We're lucky enough to have Anna as a plenary speaker at the Canadian Pain Society meeting. And Anna, you brought up something about cultural competency that I find really interesting to think about, which is, do you mind sharing that with this audience?
Oh yeah, I'm happy to. So I think if you've been trained around culture clinically, as I am, so I don't know if I said at the beginning that I'm a clinical psychologist. Maybe you did, Vina, but if you've been trained clinically as a clinician or a psychologist or nursing, you've been trained likely in competency, right? And that's how we sort of think in the systems that we work in, that we can become competent in each area. And I had shared that it's a good start. We started to think about culture. We understood that culture was a thing that was important, that we needed to start talking about. But it creates a false dichotomy, right? It creates this dichotomy that somehow we can become competent in a culture that is not our own. And that we are maybe an equal expert or have more expertise than the individual or individuals in front of us. And so myself and many other scholars and colleagues sort of advocate for us to think about cultural humility, which is sort of this next step on from cultural competence, which says, yes, just as through cultural competence, that's important. We need to think about culture. We need to have it in the room and not be afraid of it. We shouldn't be thinking about it in only the things that we see in front of us, right? Individuals make up many different things, and we cannot decide something for an individual's skin color or their ability level as they walk into a room. But we have to start thinking about those things that are on the inside and invisible but are affecting individuals. We have to start thinking about the intersections of individuals. But we have to do that with humility, with cultural humility, which is sort of lifelong learning, like being open and self-reflective, acknowledging that there's a power imbalance between the individual in front of us, and how do we make that power imbalance not go away, but sort of balance the scales in some way. And we can do that through this transparency the entire panel has been discussing, being open about this conversation, and saying to the individual in front of you, for me in mental health, it would be, I come here with my expertise in mental health and different approaches, and I'm going to be talking to you about the approaches that I think might work for you, but you're the expert in you, right? And how you've been experiencing the world and why you experience the world in the particular way that you do. And I want to work together with you to see where can we get you to in the next few months, or see where you could be in a year's time that would look like the person that you want to be. But really just being able to open that conversation as we can. I'm always open to individuals that, because I was born in the UK, goodness, that I struggle with non-anglicized names, which I hate, but I tell people that in advance, right? And I will ask somebody their preferred name. And I know some people, particularly like my Chinese clients or students, will tell me they give us another name, like they have an anglicized name instead, right? In the UK, I don't know if that's common here in Canada as well. And I'm like, is that actually your preference, or is that like a benefit to me just because I'm bad at this? And let's work. And if it is, then if that's your preference, that's what we go with. But if you'd rather something else, I'm gonna work towards doing that. So just acknowledging that I'm a human and I have foibles and I can't, I will make mistakes as well. But that we'll do that together, and we'll have conversations. And then even with the mental health pieces, we will, your voice is still important about that as well. Just because I'm coming with that expertise doesn't mean you can't question and have those conversations.
If I may just quickly jump in and say, I echo and concur with everything that Anna said. Patients have to see that they are equal partner with their clinicians, their physicians in their healthcare, and that they can ask questions, they can, speak freely. That is the only way to build trust. That is the only way to engage them at a level that will ensure their optimal well-being. Thank you.
Thank you, Lenry. No, your voice is always appreciated. And just to make sense with the other panelists, any last words you'd like to share with our audience? No, all good? Okay. So thank you all for being here. I'd like to take a moment to, again, thank all our panelists for such valuable contributions. Anna, Sam, Lenry, David, your insights are truly, truly appreciated, especially from my perspective as someone coming to this work with many different layers and many different hats. I also want to extend Special thank you to the Sick Kids Research Institute, the Child Health Evaluative Sciences Department, Dr. A.L. Cohen and Antonia Antonopoulos for their generous support in making today's event possible. If you haven't already, please sign up for the Sick Kids Pain Center membership. You can also scan the QR code on the back of your ID, and that will lead you to the Sick Kids Pain Center website. And at the bottom, you can find the link to sign up. If you can't find it, I'm sure what are some strategies when engaging communities who may have medical mistrust?
Thank you for having me. It's a really big honor to be here. And thank you to the other panelists as well. And thank you for the question. So I think this is a really important question, and I think it's easy for us to sit here and say, you know, we can build trust, we can build connections, and that will lead to, you know, better interactions. But ultimately, I think in healthcare, within the medical system, within research environments, we haven't been doing very well with this.
One of us here can definitely help you with that. You can, as a member, you can gain access to events like this. And remember, it's open to anybody interested in pain. So, you know, tell your patients about things like this, because you never know who would benefit from hearing words like this and validation like this. In addition to this, every November, we usually have a conference, and we have a wealth of resources related to pediatric pain, from the online pediatric pain curriculum course modules to videos on our Pain Center YouTube channel. If you'd like to revisit today's discussion, the full event recording will be available on our YouTube by the end of this week. So thank you all for attending today. It really makes a difference in the work we're trying to do together, because we can only do this work in community. And again, we hope that our panelists today, all of them, they really left us with a lot of food for thought and a lot to think about when we're thinking about systems of oppression, decolonizing, and just honestly, the power of listening. So with that being said, we'll move on to the networking reception, and you'll also have a chance to talk to our panelists there. Thank you.
Thank you for having me. Thank you very much.
Sorry, just adding as well that we have 3 amazing booths from the amazing resources, amazing offices at Sick Kids. So the first is Office of Patient, Family, and Community Engagement. Feel free to stop by their table. And we also have the Access, Accessibility, and Inclusion group. So again, please stop by their table. And we have the Equity, Diversity, and Inclusion Central Office here with us. So again, let's build those connections, let's build those relationships, and eat some good food. Thank you.